Localized prostate cancer. So we've got a series of speakers that really span the diversity of understanding and treating localized disease, and then we'll have another Q&A session. So be thinking about your questions, write them down as needed, and then we'll have a break for lunch. So our first speaker in this session is Dr. Paul Lange, who is the former chair of urology at the University of Washington, is the head of our Institute for Prostate Cancer Research, and he'll be talking about the diversity of localized prostate cancer. Paul?
Thank you, and thank you for coming. When you get to be as old as I do, you end up repeating yourself, and if we had more people from our group in here, they would probably be rolling their eyes when I talk about the fact that I had prostate cancer and I'm cured, and my wife complains that it didn't change me. and because I've said it a lot. Though I may be cured, I think you'll find out at the end that I might not be quite as cured as I thought. And secondly, I always talk about the shifting plates of the Earth. And I try to point out to my younger people that even though it looks like everything's stable, things actually continue to be moving. Well, this topic makes me think that we're actually going through an earthquake. And I really don't like to talk about this topic because I'm not going to be able to tell you that things are stable and the Earth really isn't moving, because it is moving so fast that I'm not too sure that I'll leave you with anything but confusion. To a researcher, confusion is great, because that means that things are happening, things are churning. If you're a patient, like you are and I am, that isn't great. You would like to have the absolute answers, but that is what we do. So, of course, being my age, I have to tell you a little history. 13 years ago, I was on the New England Journal of Medicine board, and I had to review this paper that I knew was coming. And it was the group from Sweden that said, hey, everybody, you don't need to treat prostate cancer. You can just watch it and treat it if it gets bad. And they published a paper, and I didn't like that paper at all, and I think I was overcritical, and it didn't get published in the New England Journal, but it got published very later in JAMA. And what I should have done is accepted it and maybe written an editorial and said what I did finally say, and others did too, some years later. And that is what the Swedes did, is they didn't take care of prostate cancer. They didn't do rectals. They didn't really watch it very much because they didn't think they had to. And then, after they did this for a lot of years, and then gathered only those patients who had localized disease when they were picked up, not the ones that had already had spread, they basically had accumulated an abnormal amount of what I call the turtles. That is, the ones that grow very slowly and almost never escape unless they get very big. And that these articles and the Swedish experience told us a lot about the turtles, and we kind of knew about that already because from autopsy studies, we had learned years before that a lot of men died with it and not of it. At age 80 or 90, they had prostate cancer, but they didn't know it, and it didn't hurt them. And so later on, Dr. Goldberg, for other reasons, developed a much nicer picture of the same idea, that there are the turtles, and there are lots of other animals, as Dr. Nelson will point out later. I talk about the rabbits, and then we talk about the birds, the ones that always escape, and they vary in type in terms of when they escape and when they reach a certain size. I also said, and so did others, and we knew it, that in the prostate there was a lot more turtles than there were birds. And that even then, we began to worry that if we did what we were dreaming of, that is, pick up prostate cancer early before it flies away, we were going to pick up a heck of a lot of turtles that didn't need to be treated. And if we kept treating them, then somebody else would end up telling us what to do, not ourselves. And this, as you heard from Dr. Wright, is what is evolving, that the task force said, hey, you don't need to test for prostate cancer. Actually, before that, there was a lot of talk about turtles, too. Dr. Gleason, who started the Gleason score, which many of you painfully know about, and said, well, you know, actually, some of the low Gleason scores might not be cancer at all, or if they are, they're just kind of a really, really low turtle, and we don't need to do anything about it, and maybe we shouldn't even call it cancer. And now, of course, even now, we're starting to debate the same thing over 40 years later. So the task force said, hey, you don't need to treat prostate cancer. We would say, you're wrong, and you're eventually going to be sorry you said that, but it did do a good thing because it told us that we should not be treating the turtles aggressively if we can help it. Now, in our defense, it's one thing to say, oh, we don't need to treat these turtles. It's another thing to say, when Mr. Jones says, well, Dr. Lange, do you think I can watch my cancer, and am I going to be okay? Well, we didn't actually know that for sure, and I couldn't look him in the eye and say, don't worry, you're going to be fine. I think you're going to be fine. But as we accumulated data, and as Dr. Lin will tell you later, we have much more confidence in telling patients, yes, we can just watch you. So there were different kind of animals, and initially, D'Amico, a very smart man, came across this kind of definition. There's low risk, which is PSA that's low, Gleason 6. There's intermediate risk, which is these things you see here. And then there's high risk, and the chance of recurrence, at least PSA recurrence, and we'll talk about what that means and doesn't mean, is at what you see right here. And we kind of know that the intermediate, or at least some of the intermediate, and certainly the high risk, are the birds, the ones that fly away at some point and kill. And although we've done very well, as I'll point out in a minute, we need to do better. Well, actually, D'Amico said, well, you know what? That was a little too crude. We can refine it a little bit. We can refine my old classifications. So let's take the intermediate group and divide them into those that have a Gleason 3-4 and those that have a Gleason 4-5. And when we do that, we find out that the ones that are a little worse in the intermediate group do worse. And this shows you here that the good intermediate does a lot better in terms of survival than the bad intermediate. But even then, at this many years, most people don't die from their cancer very soon, up to even 15 years. So we have risk factors that D'Amico did. Then we have other ones, like how fast this PSA comes up, how much tumor you have in your biopsy, or when you get your prostate out, whether it's at the edge, and all kinds of other things, including age, as Dr. Nelson just pointed out. And if you look at other people who took a more detailed approach at risk, such as these normograms, like the Proton mammogram, and compare it to the D'Amico intermediate groups, you find that even in the high-risk group, there are a lot of different kind of birds. There's the hummingbird that moves away very quickly, and then there's probably the ostrich, or whatever you want to call this, that doesn't fly away very fast at all. And so we realized that our risk groups were still very crude. So we're developing other things. And now when we're talking about risk, what are we talking about here? Are we talking about PSA recurrence? Well, let me just tell you right now, when your PSA starts to go up, that doesn't mean you're a dead duck. You may be an ostrich or you may be a hummingbird. There are many different classifications of PSA, and our big problem there is PSA-itis. You're worried about your PSA, and that's the illness, not the more important things, which does it spread to the bone, clinical recurrence. What about death? Is it death from cancer? And then I want to talk a little bit about total death, because this is something that keeps coming up and has been confused by a lot of people, and basically it can be seen on this slide, which isn't shown very well, but there's supposed to be boxes here, and this is all the people that die. And these are all the people that die of prostate cancer, some of which you pick up and some you don't. Guess what? It's just a very minor part of death, and that points out that even if we totally cured prostate cancer, almost, it would be very hard to show, unless you had very large populations, that it had an effect on mortality, because there's so many other reasons for people to die. Oops, what did I do here? Next. And this was in fact shown, and guess what? The same thing is true in breast, colon, and maybe even in lung and cervix, that it isn't really changing the overall death rate. What it's doing is it's changing what you die of. And so our promise with screening should not be, Mr. Jones, I'm going to get you to live longer. It's Mr. Jones, I don't know how long you're going to live, but we're going to try to stop you from dying from prostate cancer. And as you saw from Dr. Wright, the incidence of prostate cancer has gone up. We picked up an awful lot of turtles. But we also did something pretty good. We have decreased the death rate. But that death rate is still almost 30,000. That's too much. Now, screening, does it work? Yes, it does work. If you look at the European series and you do a manipulation, I don't want to get into it too much, but we are, in fact, making a dent in screening. And we have shown that if we take the prostate out as opposed to watch it if they have cancer, and in the studies we're showing that we are making a difference. So the challenge is, yes, we need to watch the turtles, and Dr. Lin will tell you about how we do that and how we can do it better. And we need to aggressively treat the birds, locally with either surgery or radiation, and we could go on about how we're doing that. And then more importantly, and I'll point this out again, that it's becoming very obvious that no matter how good we treat the local disease, we're not going to capture all the birds. So we need to do better with risk factors. And of course, the answer is molecular, because genes and messed up genes is what causes cancer. And we talked about the genes you're born with. And then we're starting to talk about the genes that are acquired, the genes that are in the tumor, as determined by the tissue. And we get into it a little bit, and hopefully in questions. And there are an awful lot of platforms, both commercial and the ones we're doing here at the universities, in terms of developing better platforms. And then I want to talk just briefly about cells to confuse you just a little more in terms of how we're developing better risk factors. Now the platforms, and this just happens to be one, is we take the tumor and then we analyze it with various genes that are on this platform, and we can do a little better in terms of developing what kind of bird you are, or if you're a bird at all. And we're doing the same thing with something called Oncoplex, and hopefully we'll be talking about that a little later, which is taking a little larger set of genes and a little more sophisticated, and developing predictive models, not only to know whether in fact you have cancer, what kind of cancer it is, how bad it will be, but how you respond to therapy. Lastly, I want to just talk about circulating cells. And last time we had this, I talked about before. We've been at this for a long time. It happens to be, and that basically is what? It's cells that are in the circulation. We call them CTCs. And in advanced cancer, that turns out to already be useful in helping us decide what to do with patients. But we've been interested more in DTCs, because that is what, in fact, that is in fact what is more important in localized disease. And I'm not going to go through all of it. I just want to leave you with one message. We do a lot of things to get these cells all taken, and we take the cells and count them and decide whether there are cancer cells there or not. And we have found that in many people, even people we think are cured, they have cancer cells in their bone marrow. And we call this dormant cancer. That is, cancer that isn't necessarily active in some patients, but can be and is in others. And we have found out that in order to really find out what's going, we need to do this in single cells. We can't just take 5 different cells and say, okay, that's cancer. We need to look at each cell and see how the cells may be different. And so we're moving more and more in this direction and looking at single cells. It's not easy to do that, and we found out that not all of the cells are cancer. Some of the cells actually have these cancer-like things on them, but they're really not cancer. They're myeloid cells, although we still have an awful lot of cells that are cancer. And guess what? I'm 15 years out from my radical prostatectomy, and I still have cells in my bone marrow. Now, are they cancer cells? They might be, but they're almost certainly cells that will remain dormant for the rest of my life. But there are others that are doing it, and this is the kind of thing that we're starting to do. This happens to be me. And in localized disease, we have, we think that what we do is we don't stop the cells from escaping or stop them escaping, but what we do is we take the cancer out and we stop the cells that have always been existing from turning into those that stick and grow. And of course, what the future is, and hopefully what you'll see later, is that when we take these more sophisticated molecular tests to predict what we're doing and what's happening, we'll do a much better job at learning who to treat and who not to treat and how to treat them. Thank you.
So Dr. Lange introduced this concept of complexity of how diverse prostate cancer is, and we know that there are a large number of newly diagnosed men that probably don't need immediate treatment, but we're trying to find out which of those do and which don't and how best we can monitor them. Dr. Lin will be talking about a very large national program called PASS that is designed to actually address these questions. Dr. Lin's a professor of urology. He's a surgeon at the University of Washington and also holds appointments here at the Fred Hutchinson Cancer Center, and he's the national principal investigator of this prostate active surveillance study. Dan?
Great, thanks. Well, thank you and good morning. And I think that we've all heard common themes, and you'll hear them repeated throughout the day today. I think they're very important. I think that understanding the behavior of this disease, it's frustrating. It's frustrating for you as patients or loved ones or family members. It's frustrating for us as physicians to try to tackle a disease that is unpredictable. However, working in generalizations, I'll be presenting some data a little bit more different from the other presentations. It'll really be looking at some research data that we've started to acquire, as opposed to just talking about in general thematic issues with regards to prostate cancer. So I'm just titling this, what are the lessons I've learned, what are the lessons we've learned from watching the turtles, from something that we call active surveillance. And I'll give you a little bit of background, dive into the data a little bit, and then have hopefully fairly high level generalizations about what we've learned with active surveillance and watching prostate cancer. And some of you in this room I know have prostate cancer and are choosing not to treat it initially. It is cancer, and it's something that this theme will arise in other cancers in the next few years. Most notably breast cancer, and I think that, I mean, my mother had breast cancer and she was treated for it, and when I look back at it now, she might not have needed to be treated for it. So I think that there are some issues that surround cancer treatment in general. So what about active surveillance? And when we think about active surveillance, and this is the background, you can read it yourself, in that clearly we have almost 250,000 diagnoses per year of prostate cancer and about 30,000 deaths from it. Dr. Wright and Dr. Lange have talked about the stage migration of disease. So we started using PSA and finding these turtles and these very slow cancers, to the point now that most of the cancer we diagnose today will be this so-called low risk or slower cancer. And then the number of new diagnoses far outweighs the number of lethal cases. We call this over-detection. And that's because, in what Dr. Lange showed, that most men that are diagnosed with prostate cancer will not die of their prostate cancer, even if it's untreated. And we know that. That's actually, it's been pretty well established. Now, of course, many men, we look at it under the microscope and we say, you have aggressive disease, you need treatment. The majority of the men also that have newly diagnosed prostate cancer, even the turtles, are still being treated. And then, of course, there are side effects to the treatments that we perform, my surgeries or radiation and so forth. And this gives you an example of what I call the changing face of prostate cancer. And this is prostate cancer over the last few years. And this would be in the 90s when PSA first started being used. And this dark orange or brown and this red are really the birds, I mean the bad disease. In fact, these are men that have prostate cancer already spread. Now, back in the early 90s, 1 in 4 men that were diagnosed with prostate cancer, it was metastatic. 1 in 4. Now you look at it now, and it's 2%. Okay, now this might change a little bit with PSA screening issues, but you look here in this landmass of green, these are the turtles that Dr. Lange was talking about. These are the slow cancers that now we're detecting at least half the time are slower appearing cancers, and what do we do with that? So this is a slide, and this is actually, it was published in a notable journal by a breast cancer medical oncologist, but it's very applicable to prostate cancer. And this is showing the stage of prostate cancer over time, and the little X there is if it's detected or not. So here's a little turtle, that over time it grew very slowly. It was detected here, and it grows so slowly that it'll never bother a man. He'll die of something else. These are the turtles, and these are the rabbits, and these are the birds that maybe never detected until they're already spread. And then there are really these snails that are never detected, but we know they're there. We know from autopsy studies that many men have prostate cancer. We just never detect it. Okay. So what we're talking about here is how to treat these guys down here. And I say that clearly not all prostate cancer is created equally. We've heard that before. Most of the day today is that there are the turtles and the snails, probably half of them, that are unlikely to harm even if not treated. There are the ones that are the rabbits that are unpredictable, and then, of course, the unfortunate birds that are very aggressive. We have a very low chance of curing them, even if we're very aggressive very quickly. And so what have we done in this setting? I'll show you this. This is the so-called NCCN guidelines. Those are the national guidelines. We sit on this panel. I think Dr. Lange sits on the NCCN guidelines representing the Seattle Cancer Care Alliance and the Fred Hutch. And if you look at that, these are the turtles. And what does the governing body of a national comprehensive cancer recommend for cancer treatment for a turtle? It says if they're greater than 10-year life expectancy, there's equality between active surveillance, and I'll tell you what that is. It's essentially just watching, versus radical therapy, and radical therapy being a surgery such as what I perform, or radiation oncology, radiation therapy or brachytherapy, which is what Dr. Russell oversees, and he'll talk about that on the next talk. And so you see there's equality of choice. There's not one that's placed higher over the other, but what's happening right now is that 90% of patients are choosing therapy. All right, for various reasons. And we're trying to learn more about who should be placed here, who should be placed here, and here. We'll learn that more through the day. So, and putting it another way, I think I look at it, and I've shown, for those of you in the audience, and I recognize some of you that have been to this symposium before, I showed this before, I think it's an easy way of looking at 100 men that are diagnosed with prostate cancer. All 100 men are diagnosed with prostate cancer, and the red ones are the low-risk turtles on the block, and the blue and the blue ones are more the rabbits and the birds, let's say. And we know that these men most likely will do well, even if we don't do anything to them. And watch them. We know that given time, these are your classic active surveillance candidates. And given time, maybe some of them will show worse disease and need treatment. And we think that we could probably definitely at least watch all the red ones. But what's happening right now is that we're really treating most of them, 90% or so. It might be more like 85 or 80% now, but we're treating most of these men. And then, of course, the side effects. So getting to what we've done, we started this study now 6-7 years ago. And it was originated here through a foundation called the Canary Foundation, with the help from the NCI, and we started it as a primary West Coast effort here, and then it generally spread across the nation at these sites, and you can read them there, where we took men that were diagnosed with cancer that they wanted to watch, or that we felt was the turtle on the block cancer. And we watched them in a very specific way, where after they said we want active surveillance, we watched their PSA, we performed multiple biopsies, and then if it appeared that they had progressive disease, such as a higher grade, instead of a Gleason 6, a Gleason 7, or instead of just a little bit of cancer, a little more cancer, we said, you probably need treatment. Now, some men decided against it, which I'll show you. If they look like they're not progressing, then they just continue the surveillance. And we obtain all these specimens here all along the way. So this is sort of a schema of how we decided to do this. And this is how we did it. We get a PSA every 3 months. We do a rectal examination every 6 months. And we do a biopsy at about the year mark, at about the 2-year mark, and then every other year. Okay? And, of course, many, many samples. And I won't go into the details. I have one slide showing that at every time point we get blood and we get urine and we make all these little samples. I'm filling freezers here at the Hutch, and they're getting on my case about it. But I think that this is really the future, to look at the tissue and to look at the serum and to understand what's going on. I'll show you a little bit of that in a minute. So all these sites feed into a central coordinating center that's here at the Fred Hutch. We have all the legal agreements to share samples with third parties, collaborators, and so forth. I'll show you a little bit of that data. And then this is how we've done. As of 2 weeks ago, we have now over 1,000 patients amongst all these different sites. And we're proud that the University of Washington and actually the Seattle VA, particularly the University of Washington, is leading this study nationally and internationally. This includes a site in Canada. I won't go through this slide too much other than just to assure you, if you look here, this is the age of our study participants. So half of them, 50%, are 60 to 70 years of age. And most of them have a PSA above 4, between 4 and 10. Very few have a high PSA. And then down here, 90%, over 90%, are the classic Gleason 3+3 turtles, so to speak, low-grade cancers. And we've been following them now for years. How they look, and what we look for is, we look for this. And you can just concentrate up here. We do these serial biopsies, and we say, is the biopsy getting worse, either worse in grade, the way it looks under a microscope, or worse in volume? And that says to us, the cancer is getting worse, perhaps the man should get treated. How have we done? And this is what we call a Kaplan-Meier curve. This is the chance that they will not have some sort of progression or treatment, and this is time. Now we're about at this level, something like the 3-year mark or so. And you can see after 3 years, men are getting numerous biopsies and PSAs, and 75% of them are still just being watched. They're not getting treated. They're getting watched because they feel and we feel their cancer is not growing. Another important slide, the last couple data slides, when one looks at the grade, when one looks at how these men are doing, now about 250 of them actually have had a progression event. In other words, their cancer looks a little worse. Out of 1,000 men, about 250 have had a progression event, and most of it's from grade progression. There have been some that have a little bit higher volume, and then there are some that have both. And what's interesting on this slide is that if they progress, let's say by grade, they have a little worse cancer in their biopsy, about 80 of the 150 decide to get treated, and about 60 decide not to. So the first take-home point is that about almost half the patients who appear to have having worse cancer with this surveillance have decided to either defer treatment or have not yet been treated. The other thing that's interesting is that there are many men, as many as a third of the men, that have been treated, but their biopsies completely look like they haven't changed. So they still look like a turtle, but yet they're getting treated anyway. We're trying to examine why that's actually happening. The treatment is mostly surgery, and most men choosing surgery have favorable pathology. So I take a man that has a turtle on the block cancer, we watch him, he needs to have treatment sometime, or he chooses to have treatment, he still has good pathology at the time of the treatment, and there's been no recurrent prostate cancer in our whole 1,000 patient cohort. The preliminary analysis, and I won't show much data for sake of time, it does appear that men that are older or men that have a little bit higher tumor volume at the time of their diagnosis do a little worse. Overall, over 90% are adherent to this schedule. They're doing their biopsies. And then importantly, there have been 10 deaths, so 1%. 10 out of 1,000 have died. None of them have died of prostate cancer. So what are the take-home messages? There's a high compliance with our protocol. Most of the participants are still on active surveillance. Many patients who show evidence of progression defer their treatment, and the corollary to that is that many patients who do not show any evidence of progression choose treatment. So they're on both sides. Most men having surgery still have favorable pathology. There is this issue about age and higher volume. And I think the last take-home is we need better biomarkers, which I'm in the pursuit of. Dr. Wright mentioned a couple of them, and I think I'll just, for sake of time, just tell you the 3 ongoing studies we have. We're looking at markers in the urine. He mentioned these 2 markers. We're looking at PSA and other related proteins like this thing called the 4K score. And then I heard earlier today about the Myriad and Prolaris and Oncotype and other assays. We're involved in those studies as well to figure out whether those assays can help us understand the disease. I'm going to skip over this and just get down to the message, which I think I showed this before. And I'm very sure that some of these blue guys can actually be watched. Very sure, and that we can find those out, and we can actually change this into this type of a picture, where we really watch all the red ones, and we treat the other ones, and in the end we'll decrease the rates of treatment, and decrease the burden of treatment, and decrease the side effects. So thank you very much for your attention.
Thanks, Dr. Lin. So we haven't really gotten into the nuts and bolts of different surgical approaches, different radiation approaches, but the panel can certainly address that with questions. But we thought it was important to revisit proton therapy. We touched on that at the last symposium a year ago. So Dr. Ken Russell is a professor at the University of Washington. He's a radiation oncologist. He's an expert in all types of radiation, whether it's the seed implants, the brachytherapy, the more standard external beam, and then also proton therapy. So he's a wonderful speaker and will give us an overview of protons in Seattle. Ken?
Can I use this thing here?
Sure.
Yes. Good morning. I'm Ken Russell. I'm a radiation oncologist. I've been taking care of men with prostate cancer since 1980. So I'd like to welcome you to this meeting. In particular, shout out to the faces in the audience who I've gotten to know both professionally and personally. I've been thinking about this metaphor of turtles, eagles, and rabbits, and just in a broader context, trying to figure out where this fits into my life and which part of my life, Paul, am I a turtle, which part am I an eagle, and which part am I a rabbit. Disclosures, with the university's permission, I serve as the medical director of Calypso, which is a division of the Varian Corporation, which makes this electromagnetic marker that goes in men's prostates for tracking during radiation. We'll not be talking about that today any further. As a further disclosure, if you ever come to my house for dinner, you know I'm a host that serves way too much food, and in the context of this morning, I have 49 slides for 15 minutes. So fasten your seatbelts, and I'm going to try not to trip over my words. So today's agenda, I'd like to give you a 30,000-foot overview of radiation for prostate cancer as a framework for why we might want to use proton radiation to treat prostate cancer, a little bit about the proton center, the workflow, the dynamics of it, how things are done, and then some of the research directions. In the world of radiation, there are a lot of choices for prostate cancer, and one of the things I want to emphasize is, although we're going to be talking mostly about protons, there are a number of different choices with external beam approaches, various acronyms for ways of aiming the beam or abbreviating the course of treatment, radioactive implants, permanent ones that are low dose rate, temporary ones that are high dose rate, combinations of the above, and all mixed with androgen deprivation therapy. This is a talk largely about protons, but radiation treatment for prostate cancer, like surgery for prostate cancer, is not one size fits all. One thing is common to all these radiation approaches is that radiation dose matters. High radiation dose is what you'd like to deliver the tumor. This has been known for a long time. This is data from Memorial Sloan Kettering based about 10 or 12 years ago. And what you're seeing on the graph here is the percentage of folks doing well as the radiation dose escalates, and this is over time. And the nomenclature in gray is also another term for 100 rads,